Let me start by thanking the organizers for this invite. It's very nice to be here and to have a chance to present on some regional perspectives on mental health from the WHO Southeast Asia region. I was very much happy yesterday to hear from several presenters about mental health and about the relevance of mental health from a public health perspective. So I will try to elaborate more to what was presented yesterday. So the objectives of my presentation today include to provide you with an overview of mental health in our region, to present some data on the burden of MNSS, mental, neurological, substance use disorders and self-harm, to share with you some insights from the PARO declaration, which was adopted by member states in 2022, and also to present some approaches in community-based mental health services and moving away from psychiatric hospitals. Let's take a look. Let's start from the beginning. Let's start from the definition of mental health. In fact, from the WHO definition of mental health. Let me read through this. Mental health is a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. You see, this is a very complex definition with many elements in it. This definition is talking about working, about being productive, importantly, about communities, and I will come back to this word community. In 2022, as I mentioned earlier, the WHO Southeast Asia region member states came together at the regional conference of WHO and adopted the PARO declaration on universal access to people-centered mental health care and services. And they committed to ensure that comprehensive community-based mental health services are established and that resources are allocated for that. Why is it so important to focus on mental health? Let's take a look at some figures. MNS, mental neurological substance use and self-harm conditions account for a significant percentage of the total burden of disease in the Asian and Pacific countries. Normally, such burden is expressed by YLDs and DALYs, so years lived with disability and day adjusted years of life. And I will present some data from country level. Here you have the WHO Southeast Asia region countries at the time this report was compiled, and you can see that in red you have the burden expressed in YLDs, in year lived with disability, in 2000 and 2019. And you can see that in the majority of cases, in the majority of countries, this is a growing burden. Someone mentioned yesterday that when communicable diseases are controlled, NCDs and mental health conditions will take over the burden. So it's very important to address such conditions. In our region, in the WHO Southeast Asia region, we estimate that approximately 289 million people suffer from a mental neurological substance use condition and self-harm. These are really big numbers. However, moving away from morbidity to mortality, we also know that many people die because of suicide in the region. More than 200,000 people die because of suicide every year, and many more attempt suicide. It is estimated that for each and every death due to suicide, there's 20 people attempting suicide. So these are really big numbers. And you can see that suicide mainly concentrate in young age groups, which is the lower part of this pyramid. This information is available in the report that was published by OECD. So to keep track of data, which was one of the first elements we had to work on after the PARO declaration that I presented earlier, WHO CIARO produced a MNSS dashboard. So a dashboard to look at regional and country-specific data on mental health conditions, substance use, self-harm, and neurological conditions. And such data can be filtered by country, by age group, by gender, and by specific conditions. This is how the dashboard looks like. I'm sharing with you the QR code in the presentation for those of you that want to take a look at this. The dashboard is also available on our website. And here you can see again in red the burden of mental health conditions. This is again in years lived with disability, which in 2021 accounts for 25+% of the overall burden. So you see this, how mental health should be a main priority from a public health perspective. As I mentioned on the dashboard, you can also filter by specific countries. Because we are in Thailand, I picked Thailand, but there's many more countries to look into, and you can see how the dashboard look like and what the most burdensome conditions are. And unsurprisingly, we have depression featuring here, anxiety, which are common mental health conditions. We also have some neurological conditions such as migraine, but we also have some less prevalent conditions like schizophrenia and psychosis in general, which generate, however, a huge disability associated to them. So again, after PARO declaration, the WHO Southeast Asia region produced a regional action plan because we didn't have any, and this is the 2023-2030 action plan, which was produced according to certain guiding principles such as life course approach, community engagement, human rights, universal health coverage, which was also mentioned yesterday, multi-sectoral action, prioritizing community care, and evidence-based actions. The objective of this plan are mainly four. There are four main areas for intervention. One is in terms of leadership and governance for mental health, and this includes mental health policies, plans, and legislation, as well as financing. Secondly is services, so to have community-based services available. The third one is on promotion and prevention, including prevention of suicide. I will say a word on that later. And the fourth one is on information system, evidence, and research. So I've been emphasizing since the very beginning of this presentation on community-based mental health. So community mental health is any form of mental health which is provided outside of a psychiatric hospital, outside of a specialized tertiary level psychiatric hospital. So this one includes primary health care. For many years, we have been working on integration of mental health into primary health care, mainly through a task-shifting approach, but also on specific health programs, for example, integrating mental health into HIV in certain settings, into TB programs, but also NCD, and so on and so forth. But also to set up district or regional general hospitals that count on psychiatric units. It's very important for general hospital to have a mental health unit, social services, but also specialized community mental health services. In other words, community-based services with specialized human resources, such as community mental health centers and teams, or psychosocial rehabilitation programs, or small-scale residential facilities. The advantages of community-based mental health is to increase accessibility, to reduce stigma, which is very often associated to psychiatric hospitals, to better protect human rights, and to improve outcomes. And this is apparently a complex figure, which I will try to explain from the World Mental Health Report on community-based mental health networks. So you can see that at the core of this figure, you mainly have three areas. One, which is purple, mental health in general healthcare. So this is about integrating mental health into what is already existing in general healthcare. This can be, for example, in PHC, but also in general hospitals, as I mentioned earlier, in specific health programs, and so on and so forth. The second element in blue is community mental health services. So these are specialized services at community level, such as community mental health center and teams, psychosocial rehabilitation initiatives, peer support services, and supporting lived services. And the third one in orange is mental health beyond the health sector. And this includes social services and non-health settings, such as schools, workplace, but also prison settings. We had a presentation this morning on it, and so on. We also produced a dedicated report to what is currently available, or what good practices are currently available in our region in terms of community mental health services. And these are some examples of community mental health centers services, which I mentioned earlier, such as centers or a psychiatric unit in general hospitals, rehabilitation services, supported living facilities, daycare, and peer support. Let's take a look at some of them. At least some of them I'm more familiar with. This is one example from Sri Lanka, is the Kudil example from a center which is a short-term residential rehabilitation facility. So housing, speaking about intersectoral collaboration, housing is a main challenge in mental health, especially for those people that experience severe mental health conditions and that sometimes don't have appropriate housing facilities or don't have housing facilities at all, and they end up on the street as homeless population. These kind of initiatives are also very important in the process of deinstitutionalization, so moving away from psychiatric hospitals, downsizing psychiatric hospitals. Yeah, maybe we can remove this. Yeah, this is more comfortable, I guess. Thanks. So moving away from psychiatric hospital and downsizing psychiatric hospital also requires establishing residential facilities, because sometimes people have nowhere to go. Obviously, the overall objective would be to reintegrate people in their own communities, to work with their own family members. But sometimes this is challenging, or sometimes this information is not even known. We don't even know where people belong to, where people come from. Sometimes people in psychiatric hospitals don't even have an ID, and they don't have a name, and they don't have an official legal status. Another interesting experience from Nepal is Koshish, and this is in terms of peer support. This initiative is very much community-oriented and is basically run by people with lived experience themselves, providing support to others. And I will say more about people with lived experience later on. This is from a recent trip to Myanmar. This is Aung Clinic based in Yangon, Myanmar. It's a small community-based initiative run by a psychiatrist, a GP, an art therapist, a sessional artist, and community mental health workers. Mental health initiatives these days obviously also include digital interventions. And here we have a good example from Thailand that is currently implementing the WHO SPS, the Step-by-Step Initiative, which is a digital, web-based, guided self-help intervention for people experiencing mild and moderate depression. So here, the contents of SPS, which were previously developed by WHO and piloted in Lebanon, have been adapted and translated in Thai and are now being implemented through a pre-existing digital platform that Thailand had already developed. And a couple of months ago, this initiative was launched by the Prime Minister of Thailand. Capacity building is another essential element when it comes to mental health. In fact, the main investment, or one of the main investments in mental health, should be in terms of human resources. Human resources are the real backbone of the mental health response. Mental health normally does not rely on expensive or sophisticated machines, lab tests. The main element and the main pillar is people. In that sense, we support countries in strengthening their capacity in mental health. And one way to do it is through the International Mental Health Workforce Training Program, which runs here in Thailand. In fact, it starts as a virtual training and then it shifts to face-to-face training. And this year, very recently, last month, we ended the third edition of this International Mental Health Workforce Training with 10 countries participating in the program itself. It's a very comprehensive and broad program covering clinical skills, but also public health skills from policy to plans, MHPSS, so mental health in emergency, suicide prevention, legislation, human rights, and so on and so forth. Speaking about suicide, and speaking about the figures that we have seen, more than 200 people dying every year due to suicide in the region, countries are also implementing the Live Life Initiative, which is a suicide prevention initiative which focuses on 4 main strategies. One is to address means of suicide and control means of, restrict access to means of suicide. This morning we learned about a very successful experience from Sri Lanka on working on pesticides and limiting and restricting access to pesticides, which in many agricultural settings represent very often the main means used to suicide. So limiting or banning access, especially to hazardous pesticides, can have a major impact in reducing mortality due to suicide. And there are very striking figures from Sri Lanka, which implemented multiple bans on suicide, each ban determining a drop in the mortality due to suicide. Obviously, in different settings, the means due to suicide can be others. The main 3 being basically pesticides, firearms, in those settings where firearms are very much available, and hanging. The second intervention of Live Life Initiative is to work with media on responsible reporting. How you report, especially how journalists report on suicide, it's very critical. It can support suicide prevention, or it can counteract it, depending on the words you use, on the images you use, on the story that you prepare. The third element is to foster skills in youth and adolescents. We have seen from some previous slides that the majority of suicides happens among youth and adolescents, at least in this region. And finally is to early detect people with suicidal behavior and to provide appropriate treatment and care. In fact, very often what happens, including in primary healthcare, is for those people that do have a suicide attempt, and maybe they end up at the hospital or they end up at primary healthcare, normally only the physical health is taken care of. If the person is intoxicated, then the people will be treated for that. If the person is bleeding, the bleeding will be treated, the cuts will be stitched. But very little is normally done in terms of mental health support and suicide prevention. And we know that the most important risk factor for suicide is a previous attempt. So we should definitely work with these people. As I mentioned earlier, human rights were an essential element in producing the regional plan for mental health. And WHO has developed an initiative which is known as quality rights initiative, which basically tries to tackle, which is basically led by the CRPD, by the Conventions on the Rights of People with Disability, and tries to tackle violations in human rights, including in mental health facilities, which unfortunately, especially when it comes to psychiatric hospital and long-stay facilities and institutions, unfortunately are very common. Recently, we had an interesting initiative to implement the quality rights in Maldives, in one specific long-stay facility in Maldives, but many other countries are working on the quality rights initiative. In this case, in the Maldives, we implemented the quality right toolkits through observations of the hospital itself, but also reviewing the documentation, the health records, and finally interviewing people living in the facility, but also staff members. Engaging with people with lived experience is fundamental. And besides and behind all these figures and numbers that we've presented on the burden of mental health conditions, behind those numbers, there's real people. People with lived experience and caregivers that are supporting people with lived experience. In this sense, we have been trying to engage as much as we can with people with lived experience themselves. This beautiful picture is from our meeting in Kathmandu last year, where we brought together more than 100 people with lived experience, including people with very severe mental health conditions, in one place from multiple countries in the region to listen to their voices. The title of the summit was Voices of People with Lived Experience in the Southeast Asia region. We also used this platform to produce the Kathmandu Charter, where basically people with lived experience reaffirmed their rights. The Kathmandu Charter, for those of you who are interested, is also available online on our website. We also produced some video interviews, which again are available on our website to document the voices of people with lived experience. I have a final comment on mental health, which is from a public health perspective. From the figures that I presented, we can see that mental health is or should be a priority. We are talking of very common conditions, highly prevalent everywhere, in all kinds of countries, in all societies, in all communities. Mental health conditions are very prevalent. And I think after COVID, all of us, we are familiar with this concept. We are talking of conditions that sometimes generate huge disability. We are talking of conditions that sometimes generate a huge burden also on caregivers. Imagine the caregivers of someone with severe mental health conditions, with someone with schizophrenia, someone with bipolar, people with dementia, and we are dealing with aging population and so forth. And we have seen an increasing expressed commitment in mental health. Everybody is talking about mental health. However, commitment in mental health is composed by several elements. One is expressed commitment, and it's important to acknowledge the relevance of mental health. And we have seen an increasing public health expression of support to mental health by government leaders and decision makers. However, this is not the only part of commitment. We also have institutional commitment. So it's very important for countries to develop appropriate mental health policies and plans and to have sufficient human resources to respond to the needs. But even more importantly, we have budgetary commitment, which means we need to allocate resources for mental health. Globally, only 2% of the overall health budget is dedicated to mental health. Despite these big figures that we have seen here, only 2%, and the majority of this 2% very often is invested in long-stay psychiatric hospitals that do not have the ability and the capacity to bridge the mental health gap at community level. So this is a very dramatic mismatch between express commitment and budgetary commitment. So this is my final message, is that it's very important to invest in mental health. We have sufficient evidence to know what to do. We need resources for doing that. I thank you very much for your attention.